This is the patient who came with abdominal pain through the emergency room, emergency department.
I'm seeing inflammation in the region of the appendix. Yeah, that structure is the appendix. It looks like there's like
So here's the appendix here.
fecalization proximally, stranding around it, secondary thickening of the cecal base and terminal ileum. Or is that, wait, show me the cecal base again. It's quite thick.
Okay, so here's the appendix here,
Mm.
right there. And then you said something about the cecal base. So here's a cecum.
Yeah. I don't like how thick the cecal base is. So I'm like, is it cecal, like, is there a cecal malignancy that caused the appendicitis? Or is it just reactive?
And the appendicitis, or the appendix.
Little
Go ahead.
foci of free air.
Yep, air bubbles right there in the retrocecal area.
Mm.
Yeah, so I felt the same way. I was like, the ceca was really thickened. The appendix, like the proximal and the mid appendix, like it wasn't, didn't have the typical appendicitis appearance, right? There's no fluid, like it's not distended, and there's some air bubbles. There's thickening here at the cecum appendix, the base of the appendix, and here, and maybe a little bit of there's stranding and free air. So this was, they did an ileocecectomy, and this was appendicitis, suppurative appendicitis with reactive thickening of the cecum. And my question is like, how do you differentiate a acute appendicitis with reactive thickening of the cecum versus a cecal mass causing secondary, thickening?
I think it's tricky, but like most important thing is to just raise the possibility so that they are careful when they go in, maybe get a frozen margin, like look at the cecum more carefully, like by visual inspection, and have a low threshold to like do an open procedure,
Yeah, yeah. Yeah, I was worried about like a mass there, and then the pathology, like I said, is just appendicitis. But like I felt bad because I'm like, if it could have just been an appendectomy, and not like have the whole like ileocecectomy. But maybe that's still within accepted standard. And then the other thing is there's a lot of inflammatory changes here. And I know, for example, like differentiating a colon mass from diverticulitis, they've shown like if you have a fascial thickening and stranding, it's more likely diverticulitis in contrast to malignancy, where malignancy you typically get thickening, lymphadenopathy, and not so much kind of reactive changes, with inflammatory changes and fascial thickening surrounding it from the edema.
Quick question. Did they say suppurative appendicitis?
Yeah.
Okay, so the air, I had read long time back, air in the appendix, yes, we always say that it's a good marker, which means the orifice is patent and it is communicating with the cecum. But if there is appendicitis and if you see air, then it is no longer a negative for appendicitis. It means there's suppuration happening. So even with the base of the appendix which is involved, that is like, should be suspicious of appendicitis, even if the mid portion and the tip is not involved.
Okay, can you repeat that? So if there's thickening of the base, it's like default to appendicitis until proven otherwise. Is that what you just said?
No, what I meant to say was, we always teach that presence of air within the appendicular lumen means it is freely communicating with the cecum, which means there is no obstruction at the appendix base, which means there is no appendicitis. But when there are features of appendicitis in which are present in this case, and then you see air within the lumen, then it is no longer a sign of normalcy, it is a sign of suppurative appendicitis.
Oh, because the air is coming from the infectious itself instead of the luminal gas.
Correct.
Oh, gotcha. That's great. Good to know.
I still think you did the right thing, and they, then they can do it open and then make the decision intraoperatively as well.
That's fair. It's an old study, and there's a lot to be learned. This is a study from outside institution, not read by us, and it was treated at the outside, but the patient came to us after treatment for follow-up and subsequent care. So what do you think?
I see a renal mass. It almost looks like there's like helices in the mass. Like I'm trying to trace that contrast coming out of the mass. Like, is there a second ureter? But in general, I'm very concerned about a renal malignancy. And
What are you
it's
going to recommend?
infiltrative. Like we always say ball versus bean. Like, is it an RCC like a ball, or is it infiltrative like a bean? And I'm wondering if it's like an infiltrative mass of like a duplicated system.
Okay, so what do you?
So that therefore like leaning towards urothelial.
Good, excellent. So this was that's what it was. After the nephrectomy. It was interpreted as a renal mass, presumed RCC. Like I said, all of this was done outside elsewhere. And they didn't biopsy, nothing. And they did a standard operation for RCC, which is a nephrectomy. And the pathology showed urothelial. And so they had to go back and then take out the ureter. So the treatment is different because you do a nephroureterectomy instead of a nephrectomy for urothelial. And like you were saying, Aarti, is it, the ball and the bean, right? So when you see something infiltrative, we typically, I mean, RCC can look like that, but UCC has to be in the differential diagnosis just because it's a completely different operative management from RCC. And so, they need to get a biopsy or, just confirm before, so you have appropriate diagnosis before, proceeding with management. And typical teaching, and maybe we don't see it here, but, UCC typically are hypoenhancing relative to the parenchyma, whereas RCCs are more enhancing and wash out of its classic clear cell. Papillary is more kind of delayed enhancement. And then the bean, typically UCCs are infiltrative, and RCCs are more balls, but you can have like aggressive RCCs that are bean shaped too. But if you see that kind of infiltrative pattern, very important to raise UCC so that they have appropriate treatment management.
Well, and could you trace that ureter somewhere? Like it looks like a ureter, but then
trace
the upper, yeah, actually you can kind of trace it right there.
Yeah, so I think right here, and then there is a here. So there's like a partial, it's not like a complete duplicated. I think it's just, it's just a really long, like you have the upper collecting system and the lower collecting that kind of merge here approximately. And then there's a single ureter that goes down to insert in the UO.
Yeah. I also learned that it's a little hard sometimes to dissect down the distal ureter at the level of the bladder. So sometimes they leave a little bit of the distal ureter. And I've seen recurrent urothelial cancer in that little distal remnant. And I'm like, why did they leave it behind? But they told me like it sometimes can be very challenging to dissect down there in the pelvis. So that's one thing to look for carefully after nephrourectomy. Okay, so this is a patient who had colon cancer with liver mets. So liver is almost considered like a regional site of disease. So, we want to describe all of the liver mets carefully so that they can see if they potentially could, do partial hepatectomy and ablate some of the other ones. Because if they clear the liver of tumor, it'll be, it could be a complete response. So this patient, anyway, had a diverting colostomy because they had a colon cancer that was resected. And this is what their pelvis looked like. And then a few months later, pelvis looked like this. And then as we keep going, this mass pops up like a few months later, basically. So what do you guys think about this mass? Do you think it's a colon cancer met? Do you think it's a primary ovarian tumor?
Krukenberg. Yes. I think it's a colon met to the adnexa.
Yeah, good. So this came up as like one of my colleagues showed me this and they said, but it's so cystic, and the colon cancer was not a mucinous tumor. And so why is it so cystic looking? Like, why can't this just be a primary ovarian tumor?
Colorectal cancer can make you cystic. I mean, mucinous.
Yeah.
Can have a cystic appearance.
Exactly. So that's the teaching point here, is that, just because the primary is not cystic, often when it hits the ovary, not the most common, sort of common morphology is like cystic and solid, and then completely solid, and then completely cystic. And of the completely cystic ones, colon cancer can do that. So the, ovarian mets don't necessarily look like the primary, but if you see something that develops like within a couple of months, it's way more likely going to be a metastatic lesion than a de novo like ovarian neoplasm. And I'll just show you the MR for fun, for correlations. You can see that it's got all these like very cystic with like lots of septations. And then it's interesting you use the term Krukenberg. Actually, there's a great article from your colleagues, Maria and Cookie, in AJR. I'm gonna bring it over, about Krukenberg tumors. And actually, Krukenberg is specifically a term for signet ring cell mucinous tumors. And those are most commonly from gastric, but otherwise that you can just call them ovarian mets. But the term Krukenberg is specifically for signet ring cell.
Oh, okay, good to know. Thank you.
Yeah. So there's a really nice article from these guys.
Can I share an article about colorectal metastasis?
Yeah.
Okay. This was just shared by, let me see. This was a big tumor, but sorry, can you see my article?
Yes.
Okay, let's see if I can make this. Okay. So the article is like this was just treatment for colorectal metastasis to the liver. So typically surgery is like this patient, I think, got surgery for colorectal metastasis to the liver. And this was a phase 3 randomized control study that was stopped halfway because they met the endpoints, showing that ablation for small colorectal metastasis is non-inferior to partial hepatectomy for transitioning patients. So it was a multi-center study. They had like over 300 patients, multiple sites, one-to-one assignment. So those undergoing resection versus thermal ablation, patients with less than 10 lesions in the liver from metastasis. And then they looked at, it was like an over 2-year follow-up. The main outcome was overall survival, and then the secondary outcomes was tumor progression, so tumor-free progression, as well as length of hospital stay, quality of life, and cost effectiveness. And they found, and it was a non-inferiority trial, and they found out halfway that they met the endpoints, which is thermal ablation is non-inferior to surgery. In addition, thermal ablation had much shorter length of hospital stay. So the other secondary outcomes were better for thermal ablation. and
That
had
makes
less
a lot of
complications.
sense, right? Because you're not like now losing so much liver tissue by doing
Yeah.
like a hepatectomy.
Yeah, and so complications, right? I mean, yeah, exactly. So complications from the procedure is very different, right? It's just less invasive. So there's less complications, shorter length of hospital stay, with similar oncologic and survival outcomes. The study suggests that perhaps maybe thermoablation should be preferred over surgery, because of decreased length of hospital stay and decreased complications with similar oncologic outcomes. This was a non-inferior study. It's not saying that thermoablation is better. It's just saying it's not inferior to surgery, at least the primary outcomes. But the secondary outcomes, it was superior because they had these other benefits.
Nice. I wonder what the surgeons will think about this. Do you know
I think it's really good. For patients, because it just increased access to care, right? I mean, and it can help patients long term in terms of complications and save money for the healthcare system by reducing the length of hospital stay, which is the driver of cost, is the actual hospital stays. So anything that we can anything we can do to reduce the length of hospital stay will really kind of move the needle in terms of savings for the larger healthcare system.
Awesome.
Okay. So we just did an appendix case. So just showing a still image, and we see contrast in the colon, right colon, and we see this tubular fluid-filled structure just lateral to the right colon. Any thoughts what this could be?
A mucocele.
That's a very good thought. And yes, it's not necessary that mucocele will have stranding around it, which is not the case here, and it's not necessary that they will have stranding. Let's see how it looks on cine. So we see that there is, does anybody
Collecting
want to
system.
describe?
There's upper tract infection or inflammation, some kind of obstruction.
Okay, so a hint, let's trace the ureter. Let's trace it on the right side.
Oh, wow. It's going lateral to the colon.
Oh, it's like an aberrant course of the ureter.
Absolutely. Let me show you.
The left one wasn't normal either.
Yeah, left is not normal either.
Is there a distal obstruction?
Say it again.
Like what's happening here? The patient just has like bilateral upper tract infections, or what's causing the hydroureter?
Before that, should I show you coronal or should I give away the answer?
Can you keep going down? I want to keep tracing the ureter.
Yeah, keep tracing the ureter. And the coronals after the axials.
I think it's not loading. Let me show you coronal.
Yes.
So that's the ureter.
Okay, and then just where does it insert?
And it's inserting normally in the urinary bladder. So the thing is, it's not congenital. It was surgical.
Oh, that's appendix. Appendix is right there. Okay, good. Yeah. Appendix is fine. Cecum is fine. Okay.
So let me give you another hint. This was not congenital. This was surgically done. Like the course of ureter was altered surgically. So basically, there was some process going on in the retroperitoneum, and that's why
there's something in the left side looks bad too. So both sides were like they're both laterally displaced.
Yeah, they are.
Oh yeah, and there's surgical resection. Was there like a liposarcoma or some kind of retroperitoneal?
There was retroperitoneal fibrosis because of IgG4. So the ureters were intraperitonealized. So this is paracolic gutter on each side where the ureters are placed.
That's
And
cool. I've never seen that. That's awesome.
let's see, like
So
this.
why is it like, is there just superimposed infection? Like what's causing all the thickening?
That is, yeah, superimposed infection, and the ureters have lost their vermiculation or peristalsis. So a lot of stasis giving rise to that.
Mm.
So this is how it looked preoperatively. There was some stranding around the kidneys, left more than the right. And these are the dilated ureters, still images again. And this is the retroperitoneal fibrosis because of IgG4. And this is just to show that, ideally when we put the stent should be lying slightly medial on the transverse processes of the vertebral body. They're super far lateral. So either there is a mass which is pushing them lateral, or there is surgically, they are like deliberately put in the lateral position in the intraperitoneum just to prevent them from being entrapped again by the fibrosis.
That's super cool. I've never seen that either. And also like I've always thought like the ureters wouldn't be long enough to be like that, but maybe because of the chronic hydro, they were stretched out. Sometimes they'll have to do little conduits or like a psoas hitch or a Boari flap to kind of like bring the bladder up. Or they'll do a conduit with like ilium. But yeah, it seems, yeah, this is interesting, but maybe they were already stretched out from the IgG4. So really interesting. Cool.
Okay. Can I show one more?
Yeah.
Okay. I'll have to stop share for. So this is a 47-year-old male comes with pain in abdomen. And sorry, I just have stills here.
See a small bowel stricture with upstream dilation. Yeah.
Like, I mean, is it just one site or are there multiple? I mean, thinking diaphragm disease in the differential.
Perfect. Yeah. I mean, there were 2 or 3 of these, and yeah, this is very short segment, very focal. This is diaphragm disease. So what could be the differentials for those? Like, why should the patient have diaphragm disease? Cause?
NSAIDs.
Perfect. The patient was not on NSAID. There was no radiation, did not have long-standing diarrhea. For
The other
celiac,
thing I would think about is Crohn's, but I mean, I guess, okay, go ahead.
that's also a good thought. There were Crohn's was negative, like no Crohn's present. The only thing that we found in patient's chart was he was on potassium supplements. And extended release potassium supplements will release potassium not in esophagus, but they go this very far in the GI tract and then release. So if you remember, if we take potassium, it's very corrosive. So even in esophagus, it can form strictures. But when it goes distally, because of this extended release formulation, it can cause diaphragm disease in the jejunum or ileum. Now the question is, why was the patient on potassium? So, I mean, this is just like, talking about diaphragm disease. So basically, patient had a rare syndrome. And before that, if you remember the diuretics, so we had loop diuretics, then we had thiazides, then we have potassium-sparing diuretics. So the patient had a rare condition known as Gitelman syndrome. And that syndrome actually acts, even if the patient is not taking thiazide diuretics, patient looks like he's taking thiazide diuretics, which means he is depleted with potassium. And when we give potassium supplements, the patient develops this diaphragm disease. So just extra piece of information. So if the patient has a genetic mutation in which he's not taking loop diuretics, but his body behaves like one, that's called Barter's. Here it was Gitelman's. And there is a third syndrome, which can be Liddle's. So what was this is the endoscopic picture. So what was done? The extended release formulation was switched from tablets to oral formulation, the solution formation, which is more tolerated. And that's about it.
Very cool. Those syndromes you just brought up though, like we would never really bring them up, right? They're like intrinsic kidney things that we don't really have imaging findings for.
Yeah, they do not have any imaging findings.
Got it. Okay, so what do you guys think about this cystic lesion here in the liver? It's got a little,
Yeah,
Gallbladder?
complicated.
what did you say, Yashant?
Gallbladder?
It's not the gallbladder. Gallbladder's here, but in the region of the hilum, there is this cystic
Yeah,
lesion, and it's got a little nodular component to it.
Yeah, IPMB.
IPNB.
Good thought. So,
Oh, there's layering stuff.
yeah,
Maybe
T1 bright. Let's see, 214 arbitrary units. Let's see if it's enhancing. Not really 217, and then on the subs, it looks like a black hole. So cyst, maybe with a little internal debris to it. So we were, not sure.
MCN.
Yep, you could think about an MCN. This
Yeah.
was a female. Or it could just be like a cyst, right? Like a hematoma with like a little complex debris in it, right? Anyway, we recommended a EOVIS scan to see like, oh, is it a choledochal cyst? Could it communicate? We did the EOVIS. This is the EOVIS here. Nice biliary excretion. Nothing was in the lesion. This T1 bright stuff was the same little nodule. So anyway, it wasn't communicating, but they decided that they were going to resect it because they were concerned about a choledochal cyst. And the final path came back ciliated foregut cyst. So,
Wow.
yeah, just a couple of things about ciliated foregut cyst. These are fairly rare. I have a couple in my files. They usually look like this, where they're in segment 4. This is kind of the classic location here. They're often just look like a normal cyst, but they can have some complexity. They're usually smaller than 3 centimeters, subcapsular in segment 4, but they can have fluid levels and be more complex. And that's when they can get resected. And usually it's kind of like a post-operative pathologic diagnosis. But in pathology, the way that they diagnose it is that it has 4 layers to it, which is pseudostratified columnar epithelium, smooth muscle layer, connective tissue, and fibrous capsule. So it looks really classic under the microscope, but I think on imaging, it looks very just like a cyst. But yeah, we've brought it up sometimes when it's up here or in segment 4 somewhere. And if it gets more complex, that's usually when they decide to resect it.
Very cool.
Okay.
Okay, we've got a high resolution T2 of this.
Rectal sigma or some kind of mass. Where is it coming from?
Yeah, it looked like it was coming from the rectal wall.
Oh.
We were referred, they said rectal mass. So we did a rectal staging protocol. I'll show you. Here it is.
It was pretty high up. Oh, there's.
Yeah. So we're like looking at the distance from the anorectal junction, from the rectal, the anal verge. Length of the tumor is 5.5 centimeters. It definitely looks like it's going beyond the T2 dark muscular ring here. Maybe
invading the peritoneum if it's indeed rectal cancer. I mean, it looks kind of like rectal cancer.
Why does it feel it is coming from outside? It has the obtuse angle.
It still has this
annular
appearance, but some of it is extending beyond.
So yeah, there's like nodes and
there's nodes. Okay, so
they didn't do a tissue diagnosis. They just went straight to staging before they got like colonoscopy and biopsy.
No, so this is one of the points of my case is final path. Actually, the path came back squamous cell. So even though we basically got this, referred as rectal tumor, do rectal protocol, we did the rectal staging, and then in the meantime, the path came back as squamous cell. And so
okay.
Yeah, I'm going to talk about it. So basically, then we discussed it at our rectal tumor board, and just going to give some points about it. So first of all, rectal squamous cell is very rare. So this is a rare thing, although we've had several cases recently of rectal squamous cell. Secondly, you should not basically use the rectal template or like the staging because it's different for squamous cell. Squamous cell is much more common of the anus or the esophagus, where you have more of the squamous columnar epithelium. So it's weird to be this high up where you don't have squamous cells, but it's possible. And we
So
don't.
would you be using like what staging template would you use? The anal cancer?
So we talked about this in our tumor board, and they basically said, describe it in all the same ways, but it's not like there's no clear guidelines of what to do with rectal squamous cell. But I looked up some papers, and basically they lean towards basically treating it like an anal squamous cell because it's much more responsive to just definitive chemoradiation than it is to surgery. So how they treated this was with definitive chemoradiation. So I guess that you can still use the rectal template to just be descriptive about where it is and everything, because they do it on a case-by-case basis and there's no standard for what to do with rectal squamous cell. But some places suggest that definitive chemorads is the way to go. So, which the anal squamous cell protocol, you don't even describe, the exact location, extent. It's mostly about the size and if it's invading adjacent organs. So I think you can just be as descriptive as possible because it's a rare tumor. And then the other thing I was going to bring up is then people say how is it possible to get a squamous cell when there's no squamous cells around? And the end result is that basically you can get squamous cell anywhere in your body. Because there can be squamous metaplasia, especially in the setting of long-term inflammation. So this is more commonly seen in patients who have inflammatory bowel disease like ulcerative colitis. That is the highest group that gets these squamous cell carcinomas. But anyway, it was just kind of an interesting one because we had a whole discussion about it. So, but yes, you're not really technically supposed to use the template for rectal cancer unless it's biopsy-proven adenocarcinoma. And that comes more into play when it's a really low tumor and there's more of a chance of it being squamous cell. Okay, so we've got some effusions, ascites. What do you guys
Is the
think?
patient getting ovarian
Ovarian
stimulation?
Yeah, exactly.
Okay.
So this was
Syndrome.
actually just after they had egg harvesting, and they have ovarian hyperstimulation syndrome. So these are huge ovaries with lots of hyperstimulated follicles. They ended up getting around 30 eggs, so that was good. And when they harvest eggs, they basically get a little tiny egg at the corner of these follicles. So these are probably just the leftover follicles from those eggs that were harvested. And then ovarian hyperstimulation can lead to ascites and effusions. It can also lead to torsion. They just treated her conservatively and she did fine. So
How do they find the egg? And is it done under imaging guidance?
yes, yeah. So when you do egg freezing, egg harvesting in any way, they basically do transvaginal ultrasound. And then they usually have a guide. And then they basically put the transvaginal ultrasound right on your ovary and then put the needle straight into each follicle and then try to grab the little egg out of the follicle.
So the egg is visible under ultrasound, transvaginal ultrasound?
I don't know, but I don't know if that or they just suck out a bunch of fluid and then see if they
And then hopefully they retrieve it. Oh, wow.
yeah. But yeah, the follicle itself is not the egg. This whole thing is not the egg. And this was actually after egg retrieval. So there was still a lot of fluid left over.
So is the fluid just because they kind of perforated the follicle and the fluid came from that, or is it just reactive fluid from the body due to just
The ascites here?
Yeah.
Oh, I think this is from OHSS syndrome. This is the
Oh,
syndrome. It causes all this leaky kind of stuff. Yeah, I don't think it's from perforating these guys. Yeah. But yeah, pretty dramatic case. Okay, I'll see you guys later.
thanks. Have a good
Thanks
day.
so
Bye.
much.
Bye.